Hi, Mike Gibson coming to you live from AHA 2022, and I have to say this is really, for me, a landmark meeting. I really think what you, Julian Gillmore, and David Lebwohl, what you have done with the CRISPR-Cas editing here in amyloid is really going to be a landmark event. So congratulations.
Thank you.
Let's talk a little bit about some of the background. Amyloid comes in a lot of different flavors, right? Wild types, genetic variants. Talk to us a little bit about that.
It does indeed. I mean, there are many different proteins that form different types of amyloid. They behave, you know, although the syndromes associated with different types of amyloid overlap, they do behave very differently.
Mm-hmm.
The condition we're talking about here is transthyretin or ATTR amyloidosis, in which the protein that forms the amyloid deposits is a protein called transthyretin.
Mm-hmm.
That can be either hereditary or non-hereditary or acquired, known as wild type. Wild type ATTR amyloidosis, predominantly a cardiomyopathy, causes a progressive and fatal heart disease, which is associated with major morbidity, very poor quality of life, actual mortality. Hereditary ATTR amyloidosis is much rarer, but there are over 130 different mutations in the TTR gene that give rise to this autosomal dominant condition that is characterized by both cardiomyopathy, as in wild-type ATTR amyloidosis, but also polyneuropathy. So
Mm-hmm.
patients with the hereditary version often have autonomic neuropathy and peripheral neuropathy.
And the split between the wild type and the genetic variants, how many do you?
So the diagnosis of wild-type ATTR amyloidosis is quite challenging, and we
Mhm.
know that until very recently, most individuals with the condition were not being diagnosed. So to answer your question, we don't really know the prevalence of wild-type ATTR
We
amyloidosis.
just don't know the denominator,
Absolutely.
and it's a little tricky to diagnose, right? I mean, it's not like you can just order check for amyloid from your lab test. So what do we need to do to raise awareness and get more testing done?
Well, so imaging has really made a huge difference. But as you point out, the most important thing is awareness. The most
Hmm.
important thing is that when a cardiologist or an echo technician sees a thick-walled heart,
Hmm.
they need to think, could this be amyloid?
Yes.
And that step is not, certainly in the UK where I work, that step is not necessarily happening.
Yes.
Once someone has thought this could be amyloid, we now have pretty good imaging techniques, including cardiac MRI.
Hmm.
In the US, you have PYP scintigraphy. We use a similar bone tracing agent called DPD.
Right.
And if one uses that particular scan, then it's diagnostic of amyloid.
Yes.
If you get uptake in the heart on those scans, it's diagnostic of amyloid. That scan in itself doesn't prove that the type of amyloid is necessarily TTR,
Hmm.
and you have to do some biochemical tests to prove that it's TTR, but you can now make that diagnosis what we call non-invasively without a biopsy. One of the problems that we had previously was that in order to diagnose amyloid, you needed a histological diagnosis.
Right.
And obviously you're not going to biopsy every case of heart failure.
Correct. Yeah. So we've made a lot of progress. Even though we've made progress in diagnostic tools, we still have a big deficit in awareness. And, I think we all hope that with better treatments, that's going to shift, right? So we've had a lot of different shots on goal out there, a lot of different companies trying a lot of different approaches. Maybe you could summarize the technology that's been used before and how this editing technology differs.
So I suppose one ought to talk about the mechanisms of possible treatment for amyloidosis. And broadly speaking, there are two mechanisms that have been employed, if you like, in terms of transthyretin amyloidosis. One is to try and stabilize the TTR tetramer.
Hmm.
The principle, I should say before that, the principle is the same in both. The principle is to try and stop transthyretin from making new amyloid.
Hmm.
The idea being that if you stop new amyloid formation, in fact, patients do actually remove some amyloid.
Well, that was going to be my
very
next question. Do you get regression
You
if
do,
you, yes.
you do.
Mhm.
But we know from experience in every type of amyloid that's ever been treated, if you like, that amyloid does regress.
Yes,
It's just that if it's untreated, patients are always making it more quickly than they're removing it.
right,
So it accumulates and the organ function gets worse.
right.
If you can stop production, you can get potentially into an equilibrium where you're removing amyloid more quickly than you're making it.
Mhm.
In other words, amyloid overall is regressing.
Yes.
So the two mechanisms to stop production are either to stabilize the TTR tetramer.
Hmm.
uh,
That's kind of the bridge bio approach.
Exactly.
Hmm.
So tafamidis was the first drug to aiming to do that, if you like, and as you know, it's approved, not necessarily widely available, but it's certainly approved for the
Hmm.
treatment of cardiomyopathy. The bridge bio approach with acoramidis is, currently in a phase
Right.
3 trial. The second approach has been to knock down the concentration of transthyretin. Initially, the initial drug to do that really was, two drugs. One was the RNA interference therapeutic, uh,
Right.
patisiran,
Hmm.
and there's now a second generation RNA, which is known as vutrisiran.
Hmm.
Second drug was an antisense oligonucleotide, simutesin,
Hmm.
and all of those drugs are designed to knock down TTR, and they do so. They knock down transthyretin levels in the serum by about 80%.
Hmm. Hmm.
This new technology that we're talking about today is obviously gene editing,
Hmm.
and that's we're using
It's a
NTA.
one and done
It's a
treatment.
one and done treatment.
Yeah.
Yeah, and the evidence that we have at the moment with NTLA-2001, which is this in vivo CRISPR Cas9 based gene editing treatment, is that this one and done treatment knocks down transthyretin more effectively, which is very, very important because in every type of amyloid that's ever been treated, the magnitude by which one knocks down the relevant protein is directly linked to outcome. So
Yes.
the more you knock it down, the better the outcome, which if you come back to the relationship between production and removal, it makes sense. If you knock down TTR by 98%, you can assume you're making it at 2% the rate that you were making it. So the
Hmm.
chances are you'll be in an equilibrium where you're removing it more quickly than you're making
Hmm.
it TCP.
Oh, yes. I mean, the tetramer stabilization people have argued that, well, you need some amyloid, and to turn it off completely, well, we saw maybe some worsening of outcomes. Is that well founded? That concern?
I don't think it is at
Yeah.
all.
Okay.
I think there's absolutely, well, two things to say. There's no evidence that knocking down TTR is harmful.
Hmm.
Certainly in human, that we've now had patients on gene silencers
Hmm.
for 10 years. A small proportion of those patients have achieved greater than 90% knockdown,
Hmm.
and that's unusual with the gene silencers, but we do have the odd patient, and there's no sign that any of them have had any clinical problems related to TTR knockdown.
So is this result durable?
And certainly, on the basis of the evidence we have so far, absolutely looks durable. There was a non-human primate study that was undertaken prior to the clinical study. The monkeys in that study were given a surrogate surrogate guide RNA specific to the monkey TTR gene, knocked down the monkey TTR from day one. The TTR levels fell and they were sustained for 367 days, which was the durability of the study.
Hmm.
The second important experiment, I think, is a mouse study in which the Intellia team gave the mice an equivalent, a mouse surrogate equivalent, if you like, and surgically removed 2/3 of the mouse livers. Uh, Following regeneration of the mouse livers, the TTR levels stayed down,
Wow.
suggesting that the drug is
incorporated into the germline.
The hepatic progenitor cells.
Amazing.
So certainly suggests that it ought to be durable. I don't know if you've got anything to add.
The study started with patients with polyneuropathy. So those patients are now out 18 months. And the same story as we've seen in non-human primates. This is durable. It looks like it's going to be maintained that entire period. And the interesting thing to think about is it differentiates it from gene therapy. I mean, I think people, they're related but different. In gene therapy, the gene is altered outside the genome, so it can get diluted over time. It's an episomal gene. In our case, you're changing the genome itself, so this will be, as far as we know, permanent from what we're seeing.
So what will be the next steps? You've studied 12 patients. What's going to be the next step? Is it to reproduce this, study larger numbers of people, begin to look at clinical outcomes? Where are you going?
I mean, I think at the moment the two things: to extend this study, obviously, to look at clinical outcomes in this study. A number of steps following that, including probably a phase 3 cardiomyopathy study, potentially a polyneuropathy study. So, really looking at clinical outcomes in more detail. But I think the first stage is really extending this study and looking at clinical outcomes in this study.
This group.
Although I have to say, if you like, the paradigm, I as a doctor, if you like, have absolutely no doubt that by knocking down TTR by 90% or greater than 90%, this drug will benefit patients. So in a sense, we're almost at the point, I would say now, where TTR knockdown ought to be an endpoint, if you like, almost a surrogate endpoint for clinical trials. I know that the FDA would never accept that at this point in time, but at the same time, as I say, the paradigm has been established that if you knock down TTR, you're going to benefit patients with ATTR.
It's a little bit like LDL. You can get approved on the surrogate, perhaps get a drug on the market, but then you have to do some post-registration kind of follow-up to show that TTR reduction is related to clinical outcomes in a much broader cohort. I'm not speaking for the FDA, but that is a path that has been used. Well, just amazing. I think this is really the highlight of the meeting, the highlight of many meetings, I think, in recent years. Congratulations to both of you. And, we're all cheering you on. This is a big disease. We don't even know how many people really out there have amyloid, but I think this will raise awareness of that, get more testing done, and we'll be able to help people.
Thank you very much.
Thank you.
Thank you.
Thanks for all of you for joining us here from AHA 2022.